We don't waste time because everything needs to be perfect. And first of all, thanks for inviting me. It's always a pleasure. I suppose that thousands of people are connected, so we have to do a great job today. So my topic is speaking about congenital uterine anomalies. You know that congenital anomalies continues to represent a great challenge, mostly for the therapeutic decision-making process. But what is important is that we need to speak the same language. So we need a clear categorization in order to plan an effective therapeutic strategy. And we have to avoid both overtreatment and also to avoid an undertreatment of these anomalies. First of all, we have to understand that these three terms, congenital anomalies of female genital tract, Mullerian anomalies, uterine anomalies, despite they are used as synonymous, they are not synonymous. You know why? Because when we refer to congenital anomalies of the female genital tract, we refer to those anomalies which affect vulva, vagina, uterus, and tubes. And these anomalies can be or cannot be associated with ovarian, urinary, skeletal, or other organ malformation. Mullerian anomalies are part of this anomaly, those anomalies that of course affect the embryologic development of the paramesonephric ducts, which are also called Mullerian ducts. And so the upper third of the two-thirds of the vagina, cervix, uterus, and tube. And regarding the fimbria, probably the fimbria has a different embryological origin. And uterine anomalies are the most part of Mullerian anomalies, so those anomalies which affect the uterine body and cervix. That's why sometimes they are used as synonymous, but it's important that you understand that uterine anomalies and congenital anomalies of female genital tract and Mullerian anomalies are not synonymous. And you know that the ESGE-ESHRE classification system has tried to put a little bit of order in the mess of the available classification system in international literature. And first of all, has established the possibility that a normal uterus can be defined, and also that a normal uterus sometimes can be associated to anomalies of other tract of the female genital tract, like cervix, like vagina. We know that the following consensus has established that if we want to do a proper diagnosis of congenital anomalies of the uterus, it's important that you do 3D sonography, because you have the coronal plane and you can see the fundal area, you can see the indentation, you can measure some angles, and so you can do a very objective diagnosis of uterine anomalies. And what is the role of the hysteroscopies? The hysteroscopy should act like a novel Galileo Galileo, that among all his discoveries is the guy who has developed the inductive reasoning, which means that hysteroscopy should always start from the analysis of the specific tract of the genital female tract, and then trying to give an hypothesis on the anomalies that is facing to. In other words, when you do an hysteroscopy, you should describe vagina, esocervix, endocervix, endocervical lesion, and then you should go to the uterine cavity and doing an estimation of the volume of the cavity, the duplicity, because in hysteroscopy you cannot say if it's a septate uterus or bicorporal uterus, because you can only say the duplicity is for less than 0.5 centimeter, 1/3, 2/3, 3/3, and the number of tubulostia. And combining this information with those obtained by 3D sonography, you can do a diagnosis of this anomaly. Let's go straight away to the treatment and analyze the most commonly presented uterine anomalies that is really related to poor reproductive outcome, despite the recent paper are trying to show the opposite. When we have to treat a septate uterus, some aims are common, whatever technique you are going to use. to do a section of the fibrotic part of the septum, leaving enough tissue on the fundal area, 1.5 centimeter. And of course, everyone is scared not being able to stop at the correct plane, and in order to avoid what is the uterine perforation that most of the time when you do septoplasty is done in fundal area. What is important is the technique that you can use. I mean, most surgeons prefer to use the standard bipolar or monopolar resectoscope. You know that you can use the knife loop shape, or you can use, I mean, the equatorial loop. You have to maintain, I don't know why the video is very, okay, let me go back. When you do metroplasty, I mean, you should always maintain to the mid plane of the septum. You can use the equatorial loop, you can use the knife-shaped loop, but however, the most important thing to maintain the same plane of cutting. Personally, at the beginning of my career, I preferred to use the 5 French bipolar electrodes because I started to do most of my metroplasty in outpatient settings. So of course, you can put these electrodes in the operating channel of all the modern operative hysteroscope, always maintaining in the mid-plane. It's also important that you can use a lateral approach using this device. And of course, because you are using hysteroscope or 4 or 5 millimeter, you can perform these procedures even in office outpatient setting with or without the use of mild sedation. And after cutting with bipolar electrodes most of the septum, you can refine the base of the septum with the use of 5 French sharp or blunt scissors in order to be safer on the fundal area. In the last years, you know that a wonderful 15 French resectoscope came out on the market, and personally I changed my way of doing these procedures. I prefer to use this device because it maintains which are the advantages of having a 5 millimeter hysteroscope. So no dilation, you can do in office setting, but the purity of the cut with minimal production of bubble, it's something very extraordinary that allows you to perform very good metroplasty both in outpatient and inpatient setting. But you know that whatever instrument you are going to use in hysteroscopy, you cannot see the fundal area. So please don't do metroplasty under laparoscopic guidance when today you have the opportunity with 3D ultrasonography to have a very accurate pre-surgical evaluation. You can evaluate you can measure in a very objective way fundal thickness and the length of the septum. But you don't know in hysteroscopy how many millimeters, how many centimeters you are going to cut, despite you have a very good pre-surgical evaluation. That's why we developed with my friend and master Stefano Betocchi an intrauterine probe, 5 French, according to which you can measure how many millimeter, how many centimeter of the septum you have cut. When you have stopped your metroplasty, you can put this intrauterine hysterometer, and so you can see perfectly how many millimeters you have cut. Like in this case, if you do the sum of the fundal thickness and length of the septum, and according to the fact that you want to leave 1 centimeter of fundal notch, you had to remove 21 millimeter of the septum. And you see that with this intrauterine palpator, you perfectly can check how many millimeters you have cut or you need still to cut. And I think that this can be a valuable tool in order to perform a more accurate metroplasty, increasing the number of optimal procedures and reducing the rate of incomplete metroplasty. However, regarding the septate uterus, we still have some anatomical issue. Not all the septa are the same. What does it mean? First of all, that the macroscopic appearance of the septum does not reflect most of the time the microscopic histology of the septum. And we have septate uterus that are the results of a pure reabsorption defect with normal fusion. These are the septa that are really very fibrotic, no vascularization, mostly in the apex of the septum. And these septa are mostly correlated to the subfertility of this patient. On the other hand, we can have septa that are more muscular, more vascularized, and these are the results of a mixed reabsorption and obscure fusion defect. And these septa are mostly related to recurrent miscarriage and preterm birth, because probably there is an abnormal pattern of uterine motility, of uterine peristalsis that can cause miscarriage and preterm birth. And recently, with the group of Fabiana Fascilla and Stefano Betocchi, we have tried to analyze what is the histology of the septum. And you know that at the moment, so we know that this part, the gray part that you see on the screen, so the wings of the septum, have a collagen tissue with muscle fibers arranged in a fusiform manner, which means like a myoma. So that's why we have that the composition of the septum in some parts is similar to a myoma. That's why Stefano Betocchi is trying to bring the concept of a new technique for not the section of the septum, but the removal, the physical removal of the septum, which means that after that you have cut the septum on the midline, you use a cutting loop in order to physically remove the fibrotic muscular tissue on the posterior, anterior, and fundal area. So we are going to perform like a sort of myomectomy that I'm sure that my friend Sergio is going to explain in the next talk. So not more the section of the septum, but the physical removal of the septum. If I stop the video here, it seems that we are doing a myomectomy. And this is the final effect in which you can see a sort of fovea after the removal of the septum. We have some other surgical issue to treat or not cervical septum, but what literature says is that is really safer, is really less complicated, easier when you face with an uterus with complete uterine septum and even a cervical septum. It's better if you remove even the cervical septum because there is no risk of cervical incompetence. So this is important because at the beginning we thought that this kind of septum could create cervical incompetence. I think that the most striking septa are those septate uterus that have also double cervix. And this is important because if you want to do a surgery which spares the double cervix, and this kind of uteri generally are associated also with double cervix and longitudinal vaginal septum, what we do with minimal invasive approach, which means that we use the mini resectoscope of the 5 French electrodes, we first remove the vaginal septum, then you see the 2 cervix. What is important is that you have to create a solution, a hole at the isthmic area, so you can put an agar, you can put an hysterometer in one of the 2 cervix, and then, I mean, you can perform a hole, a cut with your instruments, with the scissors, with the mini resectoscope, or with the bipolar electrodes in order to create a hole and then to perform the metroplasty of the intrauterine portion of the septum. Just 1 minute to explain the treatment of an anomaly that had dignity in the last 5 years, the so-called dysmorphic uteri. First of all, these parameters should be always evaluated at 3D ultrasonography in order to do a proper diagnosis of dysmorphic uteri. And we described the technique, which called home dew technique, but you can call wherever you are, so you want. I mean, the idea to create some incision on the isthmic rings that you find in the lateral wall, some incision of 2-3 millimeter deep, in order to create an enlargement at the end of the morphology and the volume of the uterine cavity. You do this cut on the left side, on the right side, and you can also do some less deep incision on the anterior and posterior wall. And the results are incredible in terms of increasing volume, increasing better morphology. But what is important, as we showed in this multi-center study that we have very good reproductive outcome. And what is interesting is that sometimes ladies that had repeated IVF failure with this uteri, we treat this uteri, and not only they get pregnant, but you see that there is a 30% of these ladies that get pregnant spontaneously, because probably we are also modifying the endometrium. And regarding complication, only some residual retained product of conception, but Luis Alonso has explained how easy is the removal of this. And keep in mind, and I conclude, that sometimes there are some mixed defect in terms of dysmorphic uteri, the so-called Y uterus, in which you have first to treat the isthmic rings on the lateral walls and then to remove the fundal septum that is quite always present in this kind of uterus. Thank you very much for your attention.